not least, Professor Thomas GEERAERTS from Toulouse, France. So we're going to talk about rehab. So please, Thomas.
Thank you, Pierre. Thank you for the organizing committee from the French Society for inviting me. So I'm not a rehabilitation physician, so I will tell you my opinion and probably the discussion we had during the writing of the French guidelines. So what we can do early in the ICU to improve recovery for a patient. So the first challenge is probably one of the most important is weaning from mechanical ventilation. We all know that it can be challenging because of associated chest trauma, rib fracture, contusion, atelectasis. So it can be challenging, especially in patients with cervical spinal injury. So it is clearly not a simple procedure, but a bundle of care that will improve and accelerate the weaning from mechanical ventilation. So we probably should perform tracheostomy early meaning before day 7, in case of upper level injury. So C2, C5 injury with a high probability of paralysis of the diaphragm. So we should probably perform early tracheostomy. Physiotherapy should be intensive in this patient, but it is clearly specific physiotherapy. So we will discuss this later. Physiotherapists should allow and accelerate bronchial drainage. So it is a specific maneuver. They should allow the cough to be assisted, and aerosol therapy could be interesting because these patients, as Sophie said, have parasympathetic hypertonia, so they are likely to have bronchospasm and increased secretion. So probably aerosol therapy could be interesting. Some papers have shown that beta-2 aerosol could improve weaning from mechanical ventilation. If the level is lower than C5, probably we should not perform tracheostomy before having tried to extubate the patient 1 or 2 times. So after 1 or 2 failure, probably consider tracheostomy, but not before. So we should try to wean the patient from mechanical ventilation by extubation, and in a majority of the case, it is possible to extubate this patient, considering the right time to try to do so. So probably after the extubation, we should perform intensive physiotherapy. There is no data on non-invasive ventilation or ventilation support after extubation. Could be an interesting study to perform, but I have no data to show you to discuss this point. Only studies on drainage and intensive pulmonary physiotherapy. Just a few words on abdominal binders, because in my ICU, sometimes I see some strange things with the abdominal binder, so I would like to discuss this point. There's an old study published more than 30 years ago, and comparing 2 types of abdominal binders. And they put these tetraplegic patients, they are in spontaneous breathing, in different positions, sitting position and tilt position in 70 degrees. First point, they measure the vital capacity, and as you see, in the supine position, the vital capacity is better than seated or 70 degrees tilt. So first important message, these tetraplegic patients have a higher vital capacity in the supine position. And there is no effect of the belt in the supine position. However, if they are seated or tilt, the belt result in a significant improvement in vital capacity. So if you use abdominal belt, use it only if the patient is seated, or in a tilt position, but don't use it in a supine position. Just few words and one movie on what we can do in early rehabilitation in ICU. So I would like to thank one of my physiotherapists in my ICU, Jean, which helped me to do this movie. So we have a patient with cervical spinal stenosis and a cervical trauma, resulting in cervical spine contusion, C3 level, and with incomplete motor deficit, so ASIA B. So this patient was early tracheostomized, and as he is in spontaneous breathing, he has abdominal belt. So what we can do is mostly passive mobilization. So the guidelines, the French guidelines are clear. We should perform passive mobilization of the joints with motor deficit. So in this case, he is C3 level, but incomplete level, but we should probably mobilize all the articulation with passive mobilization. Another very important thing in tetraplegic patient is to mobilize the hand and to allow to prevent this complication. So we should opening the thumb index commissure by doing this passive mobilization. And it is very important for the recovery. Having a correct thumb index commissure is very important for the life after the ICU. So passive mobilization, 1 or 2 times a day minimum, very important. You should also prevent neuroorthopedic limb complication. So in this patient, you will see that he suffers from spasticity, so we should prevent and treat spasticity. Sometimes we need to put in place orthesis to prevent equine, for example. In this patient, we decide not to do so because of the prevention of pressure ulcer in the limb. So passive mobilization, joint with motor deficit, and in this patient, it is upper and lower limb mobilization. So you will see that we should also do some stretching, and this stretching can be painful in this patient. He has a sensitivity, and it can be painful and produce some spasticity. So sometimes you need to give some analgesia to allow the physiotherapy to be done. So very, very important to prevent vicious position and so all these maneuver will be start from the ICU and will be continue in the rehabilitation center. So just a few words on the intermittent, the bladder catheter. So you should remove the bladder catheter as soon as possible. So it is easy to say, but not easy to perform. So we all know that if we remove the bladder catheter, you prevent urologic complications, but in the ICU, we know that it can be difficult. So, and you should also prevent pressure ulcer by allowing the patient to stay on a dynamic mattress and to put foam and pillow to prevent pressure ulcers. So, a lot of things to do in the ICU, a lot of time for one tetraplegic patient, but very important to start the rehabilitation strategy as soon as the ICU stay. So thank you.
Thank you very much, Thomas. Nice video.
Thank you.
Probably in the next Golden Gloves or something like this. So, okay, so one question from Sophie and then Tobias.
Yes, just on the video, we can see that your patient has a tracheostomy.
Yes.
So it's after the 7 days.
Yes.
He's deventilated, probably sequentially.
Yes.
I still have the urinary catheter.
Yes.
In Bicêtre, we have a physical physician that always try to make us put out the bladder catheter, because for the prognosis of this patient, it's very important. So once we take out the tube or we deventilate the patient, they have to have the bladder catheter out, and we have to make the drainage every 4 hours. What do you think about that?
Yes, I have to improve this in my ICU, but we try to remove the bladder catheter, but we have some infectious complications, so it was very difficult. So we decided to let the catheter in place with the aim to remove it as soon as possible. But I understand it is very difficult to have the staff being with the same opinion than you, because it's easy to say remove the catheter, but it's not easy to say to the nurse you should drain the bladder every 4 hours, and it's a lot of work more. So in case of busy ICU with 2 or 3 difficult patients, it can be difficult, and sometimes we have to compromise to do some negotiation with the nurse to remove the catheter. But it's life, it's real life, and this patient should not have a catheter, the bladder catheter in place. You're right.
Tobias, you want to say something?
Yeah, well, excellent video. So I have actually 2 questions. So it's a warning. So the first question is about the early tracheotomy. We frequently encounter a discussion with our surgeons about patients that have an anterior fixation, and that we would like to perform the tracheotomy early, and they say, oh, no, that's an infectious risk, because it's very close to our scar. How do you deal with that? Do you take the risk? Because I agree it's important to perform early. Second question, you were talking about preventing spasticity. Do you use frequently, or if you use it, when and based on what criteria, do you use Botox injections to treat spasticity?
So for the tracheostomy, in case of anterior surgery, so you should wait for cicatrization. So the guidelines, the French guidelines said you should probably wait for 7 days after surgery without infection or suspected infection, complete cicatrization, and you can perform tracheostomy after 7 days. So in my ICU, we wait 7 to 10 days after the cervical incision to perform tracheostomy. And second question was how to treat spasticity. Do we use toxin, botulinum? Yes, we use it, but not in the very early phase. We use it after several weeks, sometimes 3 or 4 weeks. In my institution, it is the rehabilitation physician that performs this injection. But in case of severe spasticity, we all know that baclofen is not a very efficient drug. It works, but not that much. So it is a very efficient strategy to perform injection of botulinum toxin early. It has some side effects. Even, for example, if the patient goes to the operating room, after that there is some interaction with myorelaxant, so you should be aware of that. But it is a very efficient strategy, so we use it.
Antoine, you have a question?
Yeah, thank you, Thomas. So I have 2 quick questions regarding the weaning strategy. First thing, it's recommended to try first extubations in patients with spinal cord injury C6T1. If it's, do you do that for all the patients, or is it important to consider older patients or patients with previous respiratory conditions? And the second related question, if you decide that, is it better to do that on day 1 as soon as possible, or should we wait few days to start to see possibly a neurological recovery?
I think that in case of C6 and lower level, it is probably the same patient than an ICU patient with a oropharyngeal tube. So you should probably use the same strategy. So try as early as possible and extubate as early as possible. So probably this strategy is the good one, but there is no clear evidence for that. But I think you should probably do it as early as possible. And if at day one it's okay, spontaneous breathing test okay, no complication, so try to extubate this patient probably.
Okay, thank you very much. I think we're going to close the session because it's time. Thank you again to all the speakers. I think we have a really good session. And remember that you can find all the guidelines in the eSFAR website, so you can go to the website to see all the guidelines. It's written in French and also written in English. So thank you again, and stay tuned for the Congress. Thank you.